Thank you very much for the moderator, Dr. Yaya Inaya. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Good morning, everybody. The Honorable, our international and national speakers, especially the Professor Dun John Low, professor from the Canggung Memorial Hospital. Thank you very much for your time for this event, and maybe your schedule in the first in this morning. And also the Honorable Chief of Committee, 7th ICOBTD 2022, and the Honorable to all the Dean who is participate as co-host in this event from Pajajaran University, Universitas Indonesia, from Universitas Erlangga, Universitas Sumatera Utara, and also from Universitas Indonesia. And all participants, 7th ICOBTD, ladies and gentlemen, Alhamdulillah Rabbil Alamin, all praise thanks giving to Allah Subhanahu wa Ta'ala, that we are all given health and the opportunity to all of us so we can have a chance to participate this event. As the Dean of Faculty of Dentistry, Hasanuddin University, it's my pleasure to welcome all the participants today for attendance the second session of 7th International Conference on Biophysical Technology in Dentistry 2022 with the theme Emerging Technology and Interdisciplinary Research in Daily Dental Practice. Ladies and gentlemen, 7th ICOBTD 2022 is a conference by the Faculty of Dentistry, Hasanuddin University that has been held regularly since 2018. We are very delightful that this event attracted so many participants in its series since then. As one of the largest educational institutions in Eastern of Indonesia, the Faculty of Dentistry Hasanuddin University is responsible not only for the education, but also to produce dentists who have good quality and in the same time also reliable. A dentist in this era are committed to increasing professionalism in order to update their knowledge and skills in accordance with the competence standards of Indonesian dentists. In carrying out of profession, dentists provide excellent dental and oral health services in accordance with the rapid progress of science and technology and the field of dentistry. So I would like to express my gratitude to respect of to all our honorable speakers from international and national for willing to spending time to share their knowledge and experience with us. I also thankful and appreciate of our rector of Hasanuddin University and all of the committee for all support for this event, so this event can be successful held. I hope that this 7th ICOBTD online series will be a great success, give a new hope and new knowledge as well, beneficial for dentistry students, dentists, and society. Once again, we hope that this conference will be productive and the next few hours will be enjoyable and useful to all of us. Again, thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thus, the speech delivered by the Dean of Faculty of Dentistry, Hasanuddin University. Thank you, Professor Muhammad Rusin, for a very warmly welcome speech. The next agenda is praying. The prayer will be recited by Fadil Ulum Ar-Rahman DDS, specialist in dentomaxillofacial radiology. To Fadil Ulum Ar-Rahman, time and screen is yours.
Thank you very much for the master of the ceremony. Ladies and gentlemen, all of the speakers, participants, and all of the hosts and co-hosts for today, please allow me to deliver our prayer today in Muslim way. And for the others, please take your prayer in your belief. Bismillahirrahmanirrahim. Alhamdulillah rabbil alamin, nahmaduhu wa nasta'inu wa nastaghfiruhu wa na'udzubillahi min syururi anfusina wa min sayyiatina a'malina, min yahdihillahu fala mudhillalah wa min yudhillu fala hadiyalah. Allahumma salli ala Muhammad wa ala ali Muhammad. Dear Allah, we are here in the 7th International Conference of Biophysical Technology in Dentistry, hoping for your blessing for this event and all of the speaker, participants, and host and co-host. Please make our knowledge be a useful one. Teach us anything that benefits us and keep us in the straight path of yours. Praise is only for you in every circumstance. Oh Allah, show us the truth so we can follow it, and show us the deception so we can get away from it. Oh Allah, open to us your wisdom and pour us your mercy. Forgive us for all of our sins. Dear Allah, the last but not least, please give us all the good of this world and the good of the life hereafter. Subhana rabbika rabbi izzati amma yasifun, wa salamun alal mursalin, walhamdulillahi rabbil alamin. Amin rabbal alamin. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Fadil Ulum Ar-Rahman DDS, who has been recited the prayer. May Allah Subhanahu wa Ta'ala bless us. Amin. Finally, we got the last session is closing. As the master of ceremony, I would like to thank you to Professor Muhammad Rusdin as the Dean of Faculty of Dentistry, Hasanuddin University, who has opened our event today, and for all the committee and the audience entirely. Ladies and gentlemen, even guiding this event, there were mistakes or often someone here, I would like to apologize. I'm Yaya. Have a good day and stay safe. Wassalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, back with me again, and we are going to start our main session for today. Before we begin the first session, if you have any question, kindly insert in the chat feature in your Zoom monitor below, and we'll answer it directly. And I would like to inform you all that there will be a door prize from Polyden for best participant with best question, which gonna choose by our moderator and speaker in each of session. We are now enter the main session of this event. And before we move to our main session and welcome our moderator for the first session today, let's see our moderator's profile in advance, as you can see by video on your screen right now. Thank you. Without lingering, let's welcome our moderator, Ernie Marlina, DDS, PhD, Specialist and Consultant in Oral Medicine. Time and screen is yours.
Orang Sinjai,
Orang Sinjaya, saya orang Limbung. Saya lahir di Limbung.
Kalau dengan Andre kan cuma teman dekat yang
Please, Dr. Ernie.
ya, Dr. Yaya.
Time and screen is yours, Dr. Ernie.
Ya. Halo. Apa tidak Can you hear me, Dr. Yaya?
Yes, I can. It's clearly, Doc.
Can you hear the echo as well? I try to unmute somewhere. Kindly give me a minute.
Yeah. Okay, Doc.
Okay, hello. What about now?
Yes, Doc.
Can you hear me, Dr. Yaya?
Yes, I can hear you, Doc. It's clearly, Doc.
Okay, thank you so much for giving me the time to moderate Prof. Chen. Unfortunately, I haven't seen him. At the participant list. Ladies and gentlemen, if you don't mind to wait for 5 minutes while our committee try to contact him. Yeah. Organizer, kindly display some video while we waiting for Prof. Chen to log in and join with us. We're waiting for a minute to let Professor Chen prepare his presentation. Good morning.
Hi, good morning. Yeah,
Good morning.
sorry.
Thank you so much
Hi.
for being here with us.
Yes. Yes, I'm
How
here.
are you, Prof?
Yeah, I'm fine. Sorry, I'm a little bit late.
It's okay, Prof. It's okay. Because our college let me know that you're still available for this morning. So we're waiting for you.
Okay, thank you so much.
Prof. Chen, before we begin the presentation, I would like to ask the committee to display the video of your CV. Organizer, please, the video. Excellent. What
Thank you.
a lot of projects you have, Prof. Chen. Are you still busy with any research, Prof?
Yeah, sure. Yeah.
Okay. Ladies and gentlemen, without further ado, I will leave the stage for Prof. Chen to begin his presentation about oral cancer screening program, why and how we doing it. I hopefully you enjoy the presentation. The stage is yours, Prof.
Okay. Thank you. Very kind introduction to me. So can I share my slides? Oh, I'm not able to share my slides. I'm not able to share my slides. So who can? Okay, it's work. Okay, can you see the slide? Okay, so it's clear. Okay. Okay, thank you for your invitation to me and to participate your conference, and I'm so happy and so honored to talk with this topic, oral cancer screening program, why and how. Okay, my name is Sam Listen Chen, come from the Taipei Medical University, and already know my lectures and already know me. So quickly and to go to the topic. So as we know, the for oral cancer prevention, we have 3 levels from the primary prevention, secondary prevention, and tertiary prevention. Most of us emphasize on the tertiary prevention because in clinics or in hospital, we do our best to treat a patient with oral potential malignancy and the oral cancer as well, to try to save their life. However, we still have some approach to do the prevention, including primary prevention by health promotion and some specific protections, such as the chemo prevention or vaccination. And between primary prevention and the tertiary prevention, we still have some approach, such as early detection as one of our secondary prevention. By early detections, we are able to do the prompt treatment in order to let patients progress to the late stage. Therefore, we target not so many, but many the populations, many peoples with high risk group. Then we can do the some early detection. First of all, I would like to demonstrate the global incidence and mortality for oral cancers. Nowadays, the disease burden is still very high because these cancers make this the 8th leading cause of cancer worldwide. So many patients diagnosed with oral cancer and the oropharyngeal cancer. Not only for incidence, but also for mortality. So for mortality, really unacceptable high in most countries because of the high incidence and the poor survival. As we know, for oral cancer, the 5-year survival rate is around 50% only. And this has not changed for many decades. So it's a very difficult to save life. And this is the global age standardized oral cancer incidence. And you can see the incidence of oral cancers varies with the countries. And some country like North America has a high incidence, and some country like South Asia and Central Europe and the Asia Pacific countries, again, with a very high incidence. Because of the high incidence, so therefore the mortality rates are corresponding with these disease burdens. And so I think in Indonesia has a high mortality of the oral cancer as well. So at least the selected high risk countries like following, not big surprise, in Taiwan, we have very high incidence of oral cancers compared with other high risk countries. But I think not only for the Asia country, but also for some country like Central Asia or some European country, and they have also very high incidence of oral cancer. And we need to emphasize the risk factors for oral cancers. Streets, oral habits, tobacco, quit, and alcohol. Those are established risk factors for oral cancers, as we know. For tobacco, although we have so many types of smoking behavior, most common behavior smoking cigarettes, or smoking cigars and pipes, smoking BDs. I think this is very popular in Indonesia. You can see this behavior are very associated with the risk of oral cancers, and not mention about the tobacco chewing. So it's first risk factors associated with the oral cancers. And beta quiz with or without tobacco, human carcinogens for the oral cancers. Well, so beta quiz chewing without tobacco, you can see the odds ratio is very high as well. And alcohol is also a established carcinogen for oral cancers by IARC. And you can see the dose response of the alcohol consumption are really associated with the oral cancer. So those behavior we need to take very into consideration. And for the another one is human papilloma virus. It's also significant increase the risk of oral cancers, and oral we also emphasize on the oropharyngeal cancer are strongly associated with the HPV infections. Okay, so despite the secondary prevention, for the primary prevention, we still need to target this high-risk group population by some demographic factors for the early intervention for the young population, and for middle-aged occupational group or some geographic areas. We need to target those high-risk population by including the potentials of becoming smoker or chewers, and to do some interventions. So the following ways to reduce the tobacco use evidence-based approach by health education program in school, and by some warning on the cigarette packets, and some bans, and some tobacco cessation programs, behavior therapy, and the pharmacological agents. Those have some evidence to demonstrate the reduction of tobacco use, and some some ways to reduce the alcohol use by psychosocial modification by some drugs, or with the help of support groups. Those are the primary approach for primary preventions. However, for the effect of beta quiz cessations, we don't have so many evidence-based approach for the beta quiz cessation. However, we can still use the epidemiology data to demonstrate for formal use, the risk reverse around 30% for oral cancer, but no difference for oropharyngeal cancer. We still need some evidence to demonstrate the effect of primary prevention for beta quiz chewing. Okay, let's move to the secondary prevention. For the secondary prevention, we can try to use some screening modality to screen the healthy people and or asymptomatic people, and target those high-risk group to try to do the early detection for the oral potential malignant disorder or oral cancers. Why and how? I use the Taiwan as an example to demonstrate how we do the oral cancer screening. And by the instance and the mortality curves, we look at the high instance and the high mortalities in male, the dramatic increases over time, but not so obvious the phenomenon in females. Why? Because in 20 years ago, I think we have the increase in the use of cigarettes and the equinox in the previous birth cohorts, and those high the increments of betel nuts consumption and the cigarettes, and because of that, very high prevalence of the using these oral habits behavior. So therefore, after 20 years, so many oral cancers occurrence. And by some primary prevention program, you can see after the 2003, the consumptions of those oral the cigarette or equinox or alcohol, the consumption is declined. So therefore, we still have some primary prevention approach to try to stop this behavior. However, those are fond of the use equinox or cigarettes contribute high instance of oral cancer nowadays. And for the betel quid chewing, I think in Taiwan we have very high dose of the betel quid chewing. Particularly, we have the 3 unique characteristics of betel quid chewing by the following unripe equinox. We don't cook that. We eat unripe, and we have the very high heavy dose. One time we have 1 or 2 the betel nuts, and we rather than the small pieces, and we have the betel quid without tobacco. So these are 3 unique characteristics, and this is the common types of the betel quid chewing by Lao Hua quid and the Bao Ye betel with betel quid with the betel leaf, and we have some inside some contents inside, like red lime or red limb inside, and some white slag limb in it with that. And this is some tools to make stain quid with the beta favors of the betel quid. And we also have some the different some area with a different kind of the prevalence of the betel quid chewing and the smoking. In some countries, they have a very high prevalence of betel quid chewing in some countries. And in some country, they are fond of the smoking. So we still have the various in the geography area. And So therefore, we thinking about in addition to primary prevention, could we have some early detection programs? And so 20 years ago, we have some the screening programs take place from the 1999, and in the beginning we have pilot program screening for occupational group. We know those group like drivers or laborers, they are fond of the use the tobacco quit chewing and also smoking, and therefore we screen for those the occupational group in Taipei City, try to build out a model. After that, around 2000, we have the oral cancer screening program embedded in the community integrated screening program in Keelung. Keelung is the northern part of Taiwan, and we at that time we had some trials for oral cancer screening with the totally improved and try to provide some evidence for oral cancer screening program. After 2005, we have a nationwide screening program for oral cancer and oral pregnancy. And in the first one in Taipei City, this is an article we published to show the dose-response relationship for oral habit associated with the risk of oral pregnant lesions among the men who chew tobacco quit. And at that time, we used the well-trained dentist to do the early detection among the around 8,000 participants. And those target population are including driver, technician, cleaners, and other laborers with the tobacco quit chewing. After that, we do some health education intervention. And by this program, we found that those response relationship for the tobacco quit chewing, the quantity of tobacco quit chewing associated with the oral pregnancy, and also the exposure of the tobacco quit chewing. The heavy the dose use and the frequency and the duration are high associated with the oral pregnancy. So this is one study at that period. Then after that, we do some community integrated screening targets oral cancer, but not only oral cancer, but other cancers included in this community screening program. And again, we use the previous experience to use visual inspection for the mouse, and we do some the screening. We do the not only screen but also do the referral, and also we use this platform to conduct a community-based randomized control trial to do some the evidence medicine approach to demonstrate it is possible to use total blood as adjunctive tool for visual screening rather than use dentist only. However, by this program, only slightly more leukoplakia be detected by 5%. So compared to groups, there's no significant difference between the dentist only and the dentists with totally blue. Therefore, in community-based screening program, we don't suggest the dentists use totally blue as a screening approach. And this is a randomized control trial at that time, and we invite people to enroll this interesting trial. So because of that, we still use the dentist only, combined with and also some ENT doctors, physicians to do the screening program for the whole country. And this program is subsidized by our government, and we have a biannual screening program since 2005, and by the regional inspection examination. So this is a revolution of our nationwide oral cancer screening program. At the beginning, we target at the population with age over 18 who are smoker and basically cure, and the protocol is biannual visual screening. And after 2010, we changed the age band to the age over 30, and after three years, we include Aboriginal young adults aged between 18 to 30, and also consider the high dose consumption. So this some finding from our program. We every 2 years we can have the screening, and by visual inspection, by dentist, well-trained dentist, and physician, ENT physician, and target those who are smoker or basically chewers, and the attenders per years from the beginning, we have 300,000 people to around 1 million to participate in this program. And I think in our population in Taiwan, we have around the 23 million population. Among our total population, we have around 4 million people are high risk group with a smoking or basically chewing behavior. So that's so so many people have this kind of behavior. And by this program, the positive rate is around 7.5%, and we do quite good for the referral, around 80%. For the oral premalignancy detection rates, around 4.5 per thousand, and 1.6 per thousand for oral cancer detection rate. The PPV for OPND is around 7.3%, and 2.6% for PPV for cancer. And this is one study to show the effectiveness of visual inspection examination in the high-risk group in Taiwan. It's around 2 million population with screening, and we demonstrate around 26% mortality reduction and 21% reduction in advanced cancers. So it provides the evidence to demonstrate the effectiveness of the screening program. So I think those are the our scenario why we need to have the screening. and how we do the screening. But after that, after the service program, the most important is we provide evidence to demonstrate the effectiveness of the this population-based screening program. And if we don't reach the mortality reduction, I think do the early detection is useless. Okay, so any service program we need to do the evaluation, and not only for the effectiveness, but also we do the cost effectiveness of this risk-based oral cancer screening program. So by this program, compared with non-screening, using the simulation model, and we can see in our biannual screening program, we can save cost, but gain the life year has life year gain compared with non-screening. We can save more life in effectiveness. So therefore, it's a cost saving the programs in terms of this the service screening program, and also we can do some the adjustment with the screening interval using simulation approach. If we screen 3 years or by 6 yearly or biannually, how the cost effectiveness, incremental cost effectiveness ratio will change. So you can see the scientific analysis can tell us using our current approach can bring the better the incremental cost effectiveness ratios. We can save more money. But if we don't do anything, maybe we still need to pay attention on the expenditures of the treatment in oral cancer patient, because of the late stage of oral cancer is cost a lot. So I think this is quite we need this kind of approach. So from the epidemiology data, you can see after 2004, although our incidence are still increasing from time to time, and particularly in male, but also we do a lot of the contribution on treatment. So case fatality is declines over time because the improvement of our treatment. So therefore, these two indicators contribute to the mortality rates. So mortality rate by this high incidence and the improved case fatality, the mortality rate is stably graduated. And we divided to those into the 3 age group: for the young age group, middle age group, and the elder age group. Although from the instance you can see for the middle and the elder age group, the instance is still increasing. However, the young age group, the instance is declined from time to time because of our screening program, and also combined with the primary prevention. So because the early detection of the oral pregnancy, therefore the incidence of oral cancer in young age group, I think they have some contribution for the reduction of the incidence. So from the mortality, although from the previous slide, you can see overall we don't see any change for mortality rate. However, talking with the different age group, the younger age group, you can see the mortality reduction is changed. The mortality rate is changed. Okay, so it's decreasing. Therefore, it's another way to demonstrate this good the service program. And the final part is although we do some early detection, however, from the patient side, even they have the early detection by this program. However, because some patients are still scared about the diagnosis of the oral cancer, the diagnosis. Therefore, the delayed treatment, the issue for delayed treatment still need to pay our attention. So from our data, we can see the distribution of diagnosis to treatment interval in oral cancers normally is around 20 days. However, still have some patients by early detection, but they delayed to treat after 2 months. So in our following study, we can see if the people delay treatment after 6 years, the risk of the oral cancer days will increase to 34%. So this is also very tough issue we have to deal with. Although we provide this service screening program, but we need to consider about the delays of treatment still need to work out. Okay, so from our population cancer screening program, we led the 21% mortality reduction, 21% stage the atomic cancer reduction, and 26% in oral cancer mortality reduction. And also by cost-efficiency analysis, the binary visual inspection oral cancer screening program is a cost-saving program. And we need to advise to undergo treatment no more than 6 weeks to the patients. And in the future, I think personalized screening should be suggested and to optimize and to adjust our screening program in the future. Okay, so this is my acknowledgement. My group, we always work together in the community and with our students and our colleagues, and to try to early detection of the people in the community to save people's life. Okay, thank you very much for your listening and attention. I think this is my talk today. I think questions are welcome. Thank you.
Thank you so much, Prof. What a excellent presentation, Prof. I couldn't imagine how massive and huge the effort your team have performed to do this wide national screening in oral cancer. And as you see in our chat column, there's some question, interesting question, Prof. I would like to read from Dr. Maria. Good morning, Prof. I have a question. How human papillomaviruses can be a risk factor for oral cancer? Is it any validated data for this, Prof? HPV.
For HPV, I think we don't have. Thank you for the question. Very nice question. I think for the human papillomavirus, we don't have a regular correct for every patient. But I think for oropharyngeal cancers, we do the HPV the checking for HPV because highly associated with the treatment. And we have some target therapy for that, and the efficacy is quite good. So Not for all oral cancer, but for oral pharyngeal cancer.
Oh, okay. For other oral cancer, yeah. So for oral cancer, the HFT relation isn't yet approved. Thank you, Prof. And then the second question from Dr. Isra. First, she would like to ask whether in your research, the cigarettes and the battle quit person are also alcohol free, or they doing this in combination, cigarettes and alcohol, or battle quit and alcohol?
I think only for smoker and the battle quit chewer. Because in some evidence we don't enroll the alcohol users, because we know the progression of the oral premalignancy. Actually, alcohol users are the effect of alcohol working on the progression of premalignancy to cancer, to oral cancer. So therefore, we don't include the alcohol use in the in our program.
Oh, okay.
Okay. Only for smoker and chewers. Yeah.
Okay. So in both of this group, which one has the highest oral cancer or oral malignancy, precancer lesion, Prof? Between the battle quit and the smoking group, which one that show the highest oral cancer evidence?
And for the I think for the battle quit chewer, the risk of the oral cancer are more important. And for the, because in Taiwan, most of the battle quit chewer, they have the smoking behavior as well, around the 90%. So they have the combined behaviors. So for those combined behavior, I think the risk of the oral cancer is also very high compared with the smoker only and the battle quit chewer only. But battle quit is more likely to have the oral cancer in our data. Yeah.
Oh, okay.
Yeah.
Any specific reason for this, Prof? Whether because the battle quit directly affecting the...
Because as I mentioned in my slide, our chewing behavior for battle quit are not usual. It's like a chewing gum, you know. It's like people just have a heavy dose of battle quit. They can have the battle quit chewing 20 pieces per day.
Wow.
It's very high dose.
Yeah.
Very heavy dose.
Yeah.
So they contribute a lot on the risk of the oral cancer. Yeah, I think this is a reason. Yeah.
So it's more about a doses. Yeah. Yes. Prof?
Yes.
Not the type of the agent that they use.
Yes, so that's why we have very high incidence. The top incidence, I think, in the Asia country or in the worldwide. And as far as I know, in your country, although you have some smoking PD,
Yes.
they will mix some contents, very similar content in the cigarette, but not so. The dose relationship not so strong. So compared with the use of the battle quit chewer in Taiwan, so I think
Yeah. And another interesting question from Dr. Anggun as well as Dr. Isra. In your program, when you go to the population, do they aware that they have this kind of lesion, premacular lesion or oral cancer, or they didn't realize that they have this in their mouth?
You mean the people?
Yeah, the people. Do they aware?
They actually they are aware. They actually well known about this. This is not good for the health. And also they maybe they will do the visual inspection by themselves. From the mirror. They can check their mouth whether they have the abnormal. They know, but this
they
is
just didn't realize the side effect or the long-term effect of this.
Yes, and although the people they are fond of smoking, but they are also know this is not good for, maybe not only for the oral cancer, but also for lung cancer or other cancer. But but let's still do that. So,
I know.
Yeah, and but we just provide the professional approach to let them the accessibility will increase the accessibility to them. And because we didn't have the cessation law for the beta quick chewing, but we have the law for the smoking cessation. So yeah, therefore this is a very tough public health problem in Taiwan, but we try to do our best. So that's why we have this kind of very special program for oral cancer screening.
Okay. Last two questions, Prof, if you don't mind, still from Dr. Anggun. For the visual infection, how you do this examination?
Yeah.
So it's only to see if there is any lesion in the oral cavity, or is there any specific technique to do this?
And no, not by training. We look at the oral cavity. By we still have training program for the dentist and the doctor to deliver a certification for them to have this kind of inspection program. And we have the standard, the lighter and the examination, and they need to know how to check the mouse.
They need to identify premalignant lesion as well, Prof.
Yes.
So absolutely. If you find one suspicious lesion, do you need to validate this, or it's merely from clinical?
Yeah, for some types of the oral premalignancy, we have to do the biopsy, do some biopsies.
Yeah, perfect. One last question from Dr. Ambun Manjasari. Good morning, Prof. I would like to ask a question regarding oral cancer caused by irritating trauma from the teeth. So she asks whether you found any cancer origin from dental trauma.
Yeah, in some oral cancer, we still have some caused by the dental trauma, but not much, not many. In some of our oral cancer patients.
Okay. Yeah. So not from your screening program.
Not from screening program.
Yeah. Oh, okay. Yeah, it's probably because it's hard to differentiate, Prof. Whether the cancer. In the end. Okay. Perfect. What a very interesting talk, Professor. I actually have a lot of questions, but we being limited by the time, I hopefully can meet you in person to ask a lot of questions from mine.
Yeah, me too. Yeah, me too. Yeah.
And you know, Prof, just one more thing. It's very interesting to see your data
Yeah.
about the oral cancer from ASEAN country.
Yep.
But I didn't found any an Indonesia name in this list. And I believe it is not because we don't have any oral cancer or premalignant disease in our population, but more because we don't have data from that. So we would like to learn from you how we can do the screening cancer, at least for the data, see the baseline of oral cancer and premalignant disease in our country. If you don't mind, Prof.
No, no problem. Yeah. Yeah. This is my pleasure. Yeah.
Thank you so much, Prof.
No problem. Yeah.
And ladies and gentlemen, distinguished participants, to close this session, I would like to conclude that the levels of oral cancer prevention, actually, we can do a lot of activities such as health promotion, specific protection, and primary prevention before we go to the secondary prevention, like the early diagnosis and prompt treatment. And then probably the last, if we can, and if we have a skill and fund for that, was to do the rehabilitation as a tertiary prevention. Ladies and gentlemen, there's a lot of things I can get from this presentation. I hope you can get the same. And I believe, Prof, to do this program, we need a lot of networking as well as collaboration from all.
Sorry, Dr. Emi, your audio is mute.
Yeah. So thank you, Dr. Yaya, for reminding me. Ladies and gentlemen, because we've been limited by the time, I would like to say thank you, Prof Chen, and I hopefully we can, yeah, we can learn a lot from you, Prof, in another time, in another specific program for this oral cancer screening. Ladies and gentlemen, for the next certificate handover, I will give it to Dr. Yaya.
Okay, thank you, Dr. Ernie and Prof. Chen. Maybe before we move to delivering the certificate, maybe you can choose the best question, Prof. Chen, to get the door prize from Polydent. Can you choose the best question? Or
I choose one question.
Yes,
best question.
Yes, please.
Yes, please, Prof.
Who is the best? Who is the best question?
I think the Angkang Maluna.
Anggun. Dr. Anggun, Prof.
Oh, okay.
Anggun.
Congratulations, Dr. Anggun, for being the best question for this session from Prof. Chen. Thank you so much, Prof. Chen.
Thank you, Prof.
We will send Dr. Anggun a gift from our sponsor for this question.
Okay. This is the lecture from Professor Chen. Thank you for the information and knowledge, Prof. And we would like to welcome the Dean of Faculty of Dentistry, Hasanuddin University, Professor Muhammad Rusli, in delivering the certificate to Professor Chen and the moderator. Please.
Yeah. Thank you very much, Dr. Isra. Professor Sun, thank you very much for your time to give good, excellent lectures to our audience, the participant in this ICOBTD 7. Again, thank you very much. And this is your certificate. We deliver on virtual. And also we're waiting you come to Makassar. I hope COVID-19 is go on soon, and then you can come Makassar. And also And that time I have been in Taipei Medical University, and also some of our alumni get a master and TMU in Taiwan. Again, thank you very
Yes,
much for your
welcome.
time. Yeah.
Yeah,
Thank
welcome.
You. Thank you very much.
Yeah,
Yeah.
welcome to Taipei. Yeah.
Yeah. See you.
Yeah,
See you.
Terima kasih. Terima kasih.
Ya, terima kasih.
Yeah.
Thank you.
Thank you. Thank you.
Selesai tugas pagi.
Sorry, Professor Husin, maybe for the certificate for the moderator, Prof.
Okay, thank you, Dr. Yaya Inaya. We would like to deliver also certificate to the moderator, Dr. Erni Marlina. Dr. Erni, thank you very much for your time to arrange this session.
My pleasure, Prof.
Yeah.
Thank you so much.
Thank you.
Okay, once again, thank you to Professor Muhammad Rusin, Prof. Chen, and our moderator, Dr. Erni Marlina. And ladies and gentlemen, next we will move to our second session. And before we begin the second session, let's see our moderator's profile in advance, as you can see by video on your screen right now. Thank you. Let's welcome our moderator, Christine Anastasia Rovani, DDS, specialist and consultant in endodontics. And time and screen is yours, Doc.
Thank you very much, Dr. Yaya Inaya. Can you hear my voice, Doc?
Yes, clearly, Doc.
Thank you, Dr. Yaya Inaya, for introducing me as moderator for the session. Good morning, ladies and gentlemen. Best regards to all of us, and also to our speaker today, Dr. Maria. How are you, Doc? Dr. Maria is still ready here? How are you, Dr. Maria? Thank you for your time to being here with us. Allow me, Doc, to guide your presentation of this session. In this session, in the second presentation, we will listen to the topic that will be presented by Dr. Maria with the title Biochemical, Hematological, and Histopathological Evaluation of the Acute Toxicity Potential of the Pulp Out in Wistar rats. Before we start the presentation, this is the brief introduction about her. Dr. Yaya Inaya. Thank you very much, Dr. Inaya. Welcome, Dr. Maria. How are you, Dr. Maria?
Fine, thank you, Dr. Eti.
Thank you for your time for being here with us. And for all participants, if you have any question, opinion, or suggestion, please fill in the chat room, or you can raise hand if you want to ask directly to Dr. Maria. So, Dr. Maria, this is your time, and your time to presentation is around 45 minutes. And the floor is yours now, Doc.
Thank you very much for your nice introduction. Again, good morning, dear all colleagues. I greet you virtually with happy and healthy. Before starting my presentation, I would like to express my highest gratitude to the organizer to giving me this opportunity in the 7th International Conference on Biophysical and Technology in Dentistry. My name is Maria and I'm from Conservative Dentistry Department. Excuse me, can you see my screen already? Not yet? Okay. The title of my presentation is Biochemical, Hematological, and Histopathological Evaluation of the Acute Toxicity Potential of the pulp out in Western rats. So what's the herbal medicine trends worldwide? According to World Health Organization Global Data Survey, 80% of world population, in particular in developing countries like Asia and Africa, depends on herbal medicine for healthcare due to its economical, easy to get, and easy to process. In dentistry, some herbal medicine have been used, and as we know, the famous one is clove oil. And some herbs have been studied to show the potential to be developed as a pulp devitalizing agent for root canal treatment. Pulp out is the name of combination of extracts of some herbs, which is root of sidaguri, jatropha sap, and melittin, have been studied and can cause cell death, which showed similarities image of cell death by necrosis, which is marked by changes and lysis in nucleus. So where this great idea comes from? Sidaguri, also named Sida rombifolia, is a perennial plant which is used in Indonesia folklore medicine for the treatment of gout and toothache. In India, sidaguri is used against hypertension and diabetes, and in Europe, it is used as anti-tuberculosis agent. In Australian, Aborigines use the root of sidaguri to treat diarrhea and indigestion. Root of sidaguri contains sitosterol, stigmasterol, sitosterol 3-OBD glucopyroxide, stigmasterol 3-OBD glucopyroxide, and hexacose 11-enoic acid and beta-sitosterol, which have been shown to have antimicrobial activities. In vitro study also show that sidaguri have highest antibacterial activity against Enterococcus faecalis without no activity observed on actinomyces patients. The root of sidaguri significantly inhibited carrageenan-induced pau-udem on rat. The highest inhibition, 20.78%, was showed by extract 2.4 gram per kilogram body weight, indicating an anti-inflammatory effect. Analgesic tests revealed that latency time was significant at 3.36 milligram kilogram body weight. Root of sidaguri also has potent anti-inflammatory effects on rat periapical lesion model, but lack of antibacterial activities. How about jatropha sap? Empirically, jatropha sap have been used as a mouthwash to overcome bleeding gum disorders. It's also used for relieving swelling, anti-inflammatory, and antioxidant. Phytochemical screening showed the presence of sterols or triterpenes, flavonoglycans, tannins, steroid glycosides, polyosis, and saponins. Tannin cause precipitation on protein, while saponins can affect cells and can cause hemolysis. Matulada and her studies showed that Jatropha has low pH, which can erode hard tissue components of the teeth. Jatropha also lyses blood vessels in the pulp, causing pulp necrosis. Melittin is extracted from bee venom. It is a cationic hemolytic peptide which suppresses the VEGF-A-induced tumor growth by blocking VEGF receptor 2 and the COX-mediated mitogen-activated protein kinase signaling pathway. So, the combination of these three components works synergy to get an effective devitalizing agent. Some studies have been carried out regarding this pulp out. Pulp out was able to lyse the pulp 3 to 5 days after application, depending on the dose. Pulp out also causes pulp death through necrosis mechanism. When administered to the pulp out increased the number and diameter of blood vessels, referred to the inflammation, and the expression of caspase-3 and interleukin-1 beta showed similarities to the expression of commercial devitalizing agent. Pulp out lower the microhardness of tooth structure and cause tooth porosities as evaluated by confocal laser scanning microscope. So this have shown the potential of pulp out to be developed as devitalizing agent. However, when it's applied in humans, it should be performed for safety assessment. Why? Because pulp out will be applied in the prepared tooth cavity, which means that it can leak unintentionally from temporized restoration, go into the oral cavity, enter the stomach, and then spread to other organs which can harm the body. So toxicity tests should be carried out as a measure to examine any adverse effects of a substance against systemic organs that might occur prior to its application in human. So there are lots of toxicity tests carried out to the pulp out. So this aim of study is to evaluate the acute toxicity of pulp out on visitor rats by visually observing the autonomic nervous system, body weight, water and food consumption, hematologic values, histopathologic study of intestine, spleen, liver, and kidney organs after 2 weeks administered with pulp out, and also toxicity tests to the periapical tissue. Material and methods. 12 healthy male visitor rats were used in this study and were randomly allocated into 4 groups. 1 group as control and other 3 groups were administered with pulp out in graded doses, 50 milligram per kilogram body weight doses, 500 milligram per kilogram body weight doses, and 2,500 milligram. The body weight of the rats was determined prior to the study at baseline, 7 days, 14 days. Cage site observation using functional observatory battery monitor continuously, first at 30 minutes and then regular 30 minutes interval for the next 4 hours till 24 hours and then daily till 14 days. After 14 days, the rats were sacrificed by cervical dislocation and blood samples were collected for hematological and biochemical assays, while the organs preserved in paraffin and then prepare for histopathological analysis. So this is the result. The result of the effect of pulp out on autonomic nervous systems. The parameter observed is catalepsy, ataxia, tremor, lacrimation, salivation, diuresis, piloerection, and diarrhea. In the group of 50 milligram dose pulp out and 500 milligram dose pulp out, there was no single symptoms observed, while in 2500 milligram dose of pulp out, piloerection diarrhea was observed in some rats. Piloerection actually is a defense mechanism to abrupt withdrawal of xenobiotic, when diarrhea showed side effects of xenobiotic. How is the effect of pulp out on body weights, food, and water intake? The toxic effect of pulp out observed on the basis of body weight, food, and water intake showed that all treated groups showed no significant difference compared to the control. What can be assumed from this result? It can be assumed that the metabolism of food and water were not affected by the presence of pulp out. This can also be linked to the no body weight loss observed in all treated groups. It means that there is no toxic effect of the pulp out on body weights, food, and water. So, the extract of root of sijaguri has been used to relieve toothache by drinking the boiled water of the extracts, while jatropha sap and melittin are practiced and applied directly to the egg teeth. It means that this extract actually do not harm the body. And the next toxicity test of the pulp out on hematological parameter indices. Hematological evaluation showed some variation, decrease and increase of the hematological parameter observed, like white blood cell, red blood cell, hemoglobin, hematocrit, mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, and platelet. However, this value showed no significant difference compared to the control. And the hematological parameter in control group are in the reference points for the rats. How is the effect of pulp out on spleen organ? Histological evaluation showed congestion inflammation with different category. Focal category of congestion inflammation were observed in all treated groups, while multifocal category was only observed in one group of 500 milligram dose pulp out. Below is the photomicrograph of sections of spleen in control and treated groups. Black arrow mark the congestion inflammation in treated groups. Spleen is an organ responsible in initiating the immune system, which is one of the target organs for oral xenobiotics. Congestion is an early indication of reversible spleen inflammation that can return to normal when it's no longer exposed to xenobiotic. Splenic congestion is common without any apparent cause and is seen as an excessive accumulation of erythrocyte in the red pulp sinus. In this study, focal and multifocal congestion of the pulp of the spleen observed after treated with various doses of pulp out indicated that spleen works in response to exposure of oral xenobiotics by filtering the blood and removing red blood cells, damaged red blood cells. Next is effects of pulp out on intestine organ. Histologic evaluation of intestine organ is categorized in inflammation, fat degeneration, and necrosis. Inflammation category is observed in all treated groups. Focal category, diffuse category can be observed in 50 milligram dose of pulp out, 500 milligram and 2500 milligram dose of pulp out, while no fat degeneration can be observed in all treated groups. Multifocal category can be observed in 2 rats of 500 milligram dose pulp out. Below is the photomicrograph section of intestine in control and treated groups. Black arrow marks the inflammation occur in intestine organ. So, intestine organ plays a role in immune reaction for foreign substances. Intestine epithelium is the first layer of defense mechanism against pathogens in the intestinal mucosa. When a xenobiotic or foreign substance enter the intestine, they will undergo enterohepatic circulation, resulting in repeated injury to the intestine, which might cause cell damage. These damaged cells should be replaced to restore the homeostasis after an acute or chronic attack. Multifocal necrosis observed in group 2, which means that intestinal mucosa continuously undergoes cell turnover without causing toxicity because no fat degeneration observed in intestine in histological study. Next is the effect of pulp out in liver organ. Histologic study in liver organ showed that hydrophilic degeneration was observed with different degree. There are 2 in 2 rats, each in 500 dose pulp out and 2500 dose pulp out, showed hydrophilic degeneration over 75%. Below is the photomicrograph sections of liver tissue. Black arrow mark this hydrophilic degeneration. Impairment of liver function can also be detected from the level of enzymes such as aspartate aminotransferase and alanine aminotransferase. In this study, all treated groups showed slight increase of the value of aspartate aminotransferase and relating to the dose-dependent manner, while for alanine aminotransferase, higher increase in the group of 500 milligram dose of pulp out. But this elevation value showed no significant difference compared to the control. So, what's the liver organ function? Liver is an essential organ for detoxifying chemicals and metabolizing drugs that renders it susceptible to the toxicity of substances. Impairment of liver function is marked as a rise in enzyme tests, either aspartate aminotransferase or alanine aminotransferase. Hepatotoxicity is determined when a significant increase of aspartate aminotransferase and alanine aminotransferase is around 500 microliter, accompanied with liver cell necrosis. In this study, level of AST and alanine aminotransferase is below 200 microliter. Hydrophilic degeneration is a common feature in acute toxicity that will disappear when xenobiotic exposure was stopped, and the impaired liver cells can return to normal. Histologically, observation of liver tissue showed hydrophilic degeneration in all treated groups with various degrees. So it can be assumed that pulp out has limited side effects to liver. The next organ is kidney organs. How is the effect of pulp out administered to the kidney? So histologic evaluation also showed hydrophilic degeneration with different degrees, but not more than 50%. And photomicrograph section showed black arrows mark the hydrophilic degeneration occur in kidney organ. So kidney function can also be evaluated through the level of urea and creatinine. In this study, the treated groups of 50 milligram dose pulp out and 500 milligram dose pulp out showed slight increase in the value of urea, while 2500 milligram showed a little bit lower compared to the control. But this value showed no significant difference compared to the control group. Similar to the creatinine value showed increase in the treated groups. 50 milligram, 500 milligram of pulp out, dose pulp out, and 2500 milligram showed similar value with the control group. But all these values in all treated groups showed no significant difference compared to the control group. What is the main function of kidney? It is to excrete the residual metabolic product into urine. Kidney failure can be examined by an increase in urea and creatinine level. Urea and creatinine concentration would be significant when alteration of kidney histology is approximately 75% or more. In this study, mostly treated groups showed 25% hydrophilic degeneration under histologic observation of kidney organ. It means that this is relatively mild effect to kidney organ. Next is the effect of pulp out on the periapical tissue. The parameter observed is the number of capillaries, inflammatory cells, osteoblasts, and osteoclasts in periapical tissue. Number of capillaries in treated group shows slight lower compared to the control, while for inflammatory cell showed slight increase, as well as osteoblasts and osteoclasts. Again, there's no significant difference compared to the control group. Photomicrograph of sections of periapical tissue in control and treated group in the parameters of capillary inflammatory cells, osteoblasts, and osteoclasts. In this study, just one dose of pulp out is used, which is a 50 milligram dose of pulp out, because it will be used to apply in the prepared tooth cavity. Pulp out applied to the cavity may penetrate into the periapical tissue and cause inflammation as a biological response of the immune system. In this study, inflammatory cells and number of capillaries show no significant differences compared to control group, as well as number of osteoblasts and osteoclasts. It can be assumed that inflammation has already subsided and proceeded to the proliferative phase because it's evaluated after 7 days. So the conclusion of this study, that under the limitation of this study, The application of pulp out of various doses caused mild toxicity to the organs examined without any adverse effect to periapical tissue. The authors gratefully acknowledge for the financial support of all these studies from Kementerian Pendidikan, Kebudayaan, Riset, dan Teknologi Republik Indonesia, and also for all the teams that have taken part in conducting these studies. Thank you for your attention, and the future project of this study is formulation and stability testing of pulp out paste that fulfill pharmaceutical requirements. Thank you. Hello. Hello. Thank you. Thank you. I return to the moderator.
Thank you, Dr. Maria. Sorry for the connection, and thank you for your very inspiring presentation. So now we are going to the discussion session. Can you please, if you want to ask Dr. Maria any question, opinion, or suggestion, can you kindly write down in the chat room? Or if you want to ask directly Dr. Maria, you can raise hand. I think this is a very interesting presentation, Dr. Maria.
Yeah, you're welcome, Dr. Etty.
So maybe I have a question for you, Doc, about the your research. In this research, you have used 3 doses, yeah, Doc?
Yes.
50 to 500 and 2,500 milligrams. And I see in the result, they show that the 500 milligram has a high toxicity than 2,500 milligram dose. Can you explain about that, Doc?
I think this is then an individual response of rat, because we noticed that these rats in particular also show other different evaluation in other toxicity tests. Maybe because of the a little bit slight lower body weight of one of these rats.
Okay. So it depends on the sample, okay? Because you use Wister rat in this in your sample.
Yes.
But it's not significantly different, okay? But it's a little bit higher than the biggest dose that you use in this research.
Yes. Because
yes, Doc.
It's difficult to make an assumption because this is all the toxicity is about. So because there are so many parameters that have to be evaluated regarding this toxicity test. So we cannot depend just only for one parameter used.
Thank you very much, Doc, for your explanation.
You're
welcome. Any question for the participants, maybe?
Mrs.
Yes. Dr. Yaya Inaya, how about the time? What time we have still have time to discussion? Because I think it's almost 12 o'clock.
Yes, Dr. Eti, maybe we can close the session because it's Friday for the Muslim to take a pray.
Okay, I think if any participants want to ask the question, we can fill in the chat room for. Sorry, Dr. Maria, because we have a limit time for today because it's Friday. So maybe before we close this session, I would like to give the conclusion that PARP out, which is a combination of Jatropha jump pest, Sidaguri roots, and Melittin pest, show the low acute toxicity in test organ of Vista rats without any adverse effect to periapical tissue. So that PARP can be developed as an alternative PARP devitalizing agent. So thank you very much, Dr. Maria, for your time and for certificate delivered. I will give it back to our master ceremony, Dr. Yaya. Thank you very much, Dr. Yaya. Dr. Yaya.
Thank you. This the lecture from Dr. Maria Tanwiharja, DDS Master of Dental Science. Thank you, Dr. Maria, for the information and the knowledge. And now we would like to welcome the Vice Dean, Dr. Edi Habar, DDS, Specialist and Consultant in Orthodontic, in delivering the certificate to Dr. Maria and our moderator, Dr. Christine. For Dr. Edi, please, Doc.
Thank you for Dr. Edi and Dr. Yaya for the certificate.
Okay, thank you very much for Dr. Yaya, and thank you very much for Dr. Maria for the very interesting and very informative presentation. And this is your certificate, Doc?
Yeah, thank you, Doctor.
Yes, thank you very much.
You're welcome.
Okay. And the next certificate to Dr. Christine. Thank you very much, Dr. Christine, for the moderator to this session. Thank you very much.
Okay, once again, thank you to Dr. Edi Habar, Dr. Maria, and our moderator, Dr. Christine. And ladies and gentlemen, now is break session, and the next session will be start at 1 p.m. And for the participant, you can join again before the third session start. Thank you.
Oh, unmute, Dr. Yaya. We cannot hear your voice.
Okay. Sorry, Doc. Ladies and gentlemen, now it's the break session, and the next session will be start at 1 p.m. And for all the participants, you can join again before the third session start. Thank you.